Welcome to my CCS case review series. I'm going to run over with you important things not to miss on the exam, some key tips that I think will snag you a lot of points, and then we're going to do some questions and cases just to see what I mean, and things that really commonly come up on the test that I think will be helpful for you. Okay, so here are some just general tips, okay, ordering tips. When you put in your orders, make sure you know the difference between stat and routine. Stat is going to be usually associated with abnormal vitals. Some vital sign is abnormal. This person might be pregnant. Something that is life-threatening, you definitely want to put it in there as stat. Make sure you never order something routine when it should be stat. They are more likely to ding you for ordering something routine when it should be stat than ordering it stat for when it should be routine. So when you're totally unsure, just order it stat, and I think you're more likely to get more points, okay? Don't forget to change locations. That's another key one. It's very easy to stay in the clinic or stay in the home setting because you're not actually doing the case, right? So it's always important to know when to go from home to the ED, and then when to go from the outpatient clinic to the ED, and then from ED to inpatient, and then inpatient back to home. Those are some key location changes that you have to know how to handle. So after they're stabilized in the ED, move them to inpatient, okay? After they've been treated inpatient and they're stable from there, they can go home, okay? Always move the location, especially going to the ED is an important one for patients, because they often won't start you off in the appropriate location. They'll ask you to be able to navigate the patient's care to the appropriate site. Okay, so that one is also key. Location changes, it's very commonly ignored, and it's a great site to lose points. Emergency orders. These are some emergency orders that if you don't know anything, you can throw them on there and just maybe get a few points. Okay, that includes IV access, NSS. Always, in a ton of cases, if you don't throw an IV access, you'll lose points. Okay, NSS is normal saline. That's the order in the test that it's going to be there for you. Cardiac monitoring, BP monitoring, those are all orders there. Pulse ox, Q1, oxygen therapy. So basically this is all vitals monitoring. Vital signs, Q1, ECG, troponins, blood glucose, and neuro checks. These are all emergency orders that if you throw them on there, I don't think they'll ding you in an emergency case. Inpatients, okay? Inpatient orders, you need to remember that they need just some active baseline orders for these people. Activity, diet, DVT prophylaxis, vital signs Q8, and routine labs are all there for you to order in these kinds of cases, okay? So make sure to also have your inpatient order set memorized, your emergency order set memorized. If you have these in the back of your head, you'll gain a lot of free points on test day. Then surgery. A ton of patients are going to require surgery on the test. Okay, so remember, NPO, type and screen, coags, antibiotics. Every single surgery case has those. They'll be very useful for you, okay? And for antibiotics, it's a very simple decision. Is it an abdominal surgery or not? And if it's not, you're going to go with straight old classic cefazolin. If it is, you'll go ceftriaxone flagyl, all right? Also remember to put in a Foley after or before the surgery, and do urine output checks Q8 to monitor for kidney function. So perfect. Surgery. We have NPO, type screen coags, antibiotics, Foley, and urine check. Okay. In women are always going to require some kind of HCG. They'll give you a reason to test for pregnancy in most cases, okay? If they are pregnant, it's very important. Prenatal vitamins, prenatal iron, ultrasound, prenatal counseling. And usually won't be mad if you throw in an STD check as well. So these are some key tests to remember for women, especially if they're pregnant. If there's any chance of bleeding or future bleeding, always remember to get coags type screen for potential transfusion down the line. All right. Pain. Never forget to treat pain. Whether it's NSAIDs, low dose opioids, or high dose opioids like the ones I've listed here, never forget to treat pain, and always look for contraindications to specific pain medication, because they'll try to get you there as well. All right, so start off easy with NSAIDs, then you can go to the low potency opioids, and then the high potency ones I've listed here at the end. And also don't forget counseling, reassurance, and follow-up visits. Okay, these things you throw in at the end. So this is the end of your case, and then in the beginning you always want to check stat orders, and don't forget to locations change. So this is the beginning to end, all this stuff is in the middle. All right, moving on. Let's run through a quick case. I'll go through a couple of different case situations, and I'll tell you what to look out for in terms of the orders. Now, this is going to help you generally organize what you should throw in there and what you shouldn't. Obviously, on test day, you might miss a few of these points, but this will be helpful just as a general overview and help you to think of some points or ideas, things not to miss when you have these cases. Generally, if you put in orders in slightly different than what they have, as long as it's there, they won't totally kill you for it, but they do have order preference. All right. So our first case here is going to be a simple case of cystitis, uncomplicated in a woman. Okay, so let's say this is a woman. Always you want to do a HCG in women, right? In every case, because especially cystitis, because it has two treatment paths down an algorithm. Each one has its own algorithm, whether you're pregnant or not. Remember, non-pregnant people can get a 3-day course of stuff. Pregnant people have to get a 7-day course of stuff. TMP-SMX is the classic one for non-pregnant people, and nitrofurantoin is the classic one for pregnancy. The one thing you should remember also is sometimes they'll throw in an allergy just to mess with you, since uncomplicated cystitis is a pretty simple case. So if you have an allergy to sulfa drugs, TMP-SMX, you can also do 3 days of fluoroquinolones, right? Ciprofloxacin is a good one. 7 days of nitrofuran. If they're allergic to that, you can also do 7 days of amoxiclav. So remembering the alternative medications is also a great one for uncomplicated cystitis. Don't forget 3 days, 7 days, TMP-SMX and fluoroquinolones versus nitrofurantoin and amoxiclav. UA urine culture, so you know what you're dealing with, and once they're stable, you also want to do antibiotics, prenatal vitamins, and counseling. If the prenatal vitamins, especially if they're pregnant, counseling you want to throw in at the end of every course, sexual history counseling, things like that with recurrent and complicated cystitis cases, and a follow-up in 2 weeks. The follow-up time is also important here. Make sure you know how long before the next period. Sometimes it's going to be 2 weeks, usually it's going to be somewhere around 3 months. It really depends on the case. Okay, hopping into the next case. We're going to run through 10 cases here altogether, so we have a pretty comprehensive understanding, and I'll just blow through them pretty quickly. This is a case of a new pregnancy. So the patient comes in, they have some nausea, they've had recent unprotected sex. What do you want to do for pregnancy? So after you've diagnosed it with the HCG, blood type, antibody screen, rhesus screen, CBC-CMP, PAP are all very good tests after someone's recently pregnant. Then you don't want to forget rubella, syphilis, UA culture, Hep B, HIV, and chlamydia. Now I know I've just thrown a million things your way, but these ones are actually vital. So don't forget these on the exam. Then these ones are kind of optional. If the person's at risk of exposure, you can throw these in if there's some clue in the history. Then don't forget to do an ultrasound to assess the fetus. Prenatal counseling is towards the end with vitamins and prenatal iron. And then you want to schedule follow-ups, right? Definitely have a follow-up for oral glucose tolerance if you're past 25 weeks, for GBS at 37 weeks. And here's kind of how you schedule follow-ups, which is pretty crucial in pregnancy, right? Every 4 weeks at the second trimester, every 2 weeks towards the end, 36 weeks plus, right? Until 36 weeks. So 28 to 36, you're doing every 2 weeks. Before that, you do every 4 weeks. And then every week after you've crossed this 36-week barrier. So once you're at 37 weeks plus, you're going to do, when you're at term, you're going to follow up pretty much every week. Because in a lot of cases, the OB will just choose to induce at term, so you can have the pregnancy when it's convenient for you. Okay, so that's a rundown of new pregnancy tests. Definitely things you don't want to forget are the type and screen, the rhesus, the CBC, the PAP, the RPR, and the rubella testing. Also, you can throw in there chlamydia and things like that, depending on, like I said, the chances of exposure. All right, so moving on to our third case. Our third case is going to be a case of ulcerative colitis. Now, what do you want to look out for here? So you're going to have really making the diagnosis in these cases are not going to be so bad. You want to start off in this ulcerative colitis case definitely with a CBC because they're bleeding. Any bleeding case needs CBC BMP, right? And a lot of these IBS, IBD cases, the one thing that they want to get you with is that you didn't order a stool, ova, and parasite. That should always be on your mind in these cases, and it will always snag you points. Stool, oval, parasite, stool white cell count, stool bacterial culture. You want to rule out infection before you jump to IBD, right? Then also in ulcerative colitis, because you're suspecting ulcerative colitis, you want to get LFTs. You want to make sure you're not getting a PSC situation where you have a sclerosing cholangitis as a result of your UC that you haven't detected. And also remember, any bleeding case, PTT INR is also crucial. ESR is a great one. It's very non-specific, but it will snag you points because it does tell you that there's some non-specific inflammation going on. Sigmoidoscopy is going to clinch the diagnosis for you in this case. And then these are all the labs we already talked about. So then once you've got the diagnosis pretty much clinched and you know what you're dealing with, you want to bring the patient to the office outpatient and start treatment. You don't have to start, you can start treatment in the inpatient unit, but after you've confirmed the ulcerative colitis, you continue the treatment outpatient, or you can even start the treatment outpatient once your colonoscopy results have been read. So that's mesalamine and loperamide, right? Mesalamine is going to be your 5-ASA drug. It's going to control your inflammation, and loperamide is going to stop your diarrhea. You can also throw in a dicyclamine. That's a more new one. It controls, it's an antispasmodic that's helpful for IBS type symptoms, and a dietary consult. So this is towards the end of our case. We always want to remember what kind of peripheral things we're looking for, what kind of follow-ups that we might not consider just purely on lifestyle factors. So dietary is a great one for these kinds of cases, right? Steroids can be used for moderate and severe cases of flares of UC, and always remember folate supplementation as well. 5-ASA is a drug that can deplete folate stores, especially if you're having a bunch of diarrhea at the same time. So remember, dietary consults, folate supplements, these are the things that can get you right over the border and get you an excellent score on this kind of case, okay? And then after that, you want to schedule colonoscopy 8 years after diagnosis. That's going to be also an important point to mention, okay? So that's kind of the ulcerative colitis in a nutshell. Not too bad, really. Remember, when the patient comes in, they're bleeding, so CBC, BMP, coags, LFTs, stool, any kind of GI case, you definitely want to rule out infection. So stool OMP, stool white count, stool bacterial culture, usually they won't ding you for those cases, okay? So throw those in there, get those results to rule out the differential. All right, moving on to our next case. Ectopic pregnancy. Now, this is a great one because it requires surgery, and like we talked about, you need to know the surgery order set for anyone who has any kind of surgical issue. Remember NPO, remember the antibiotics, remember that the person needs a Foley, and they're going to need coags before they go into surgery, right? And type and screen. All right, so the person comes in, the woman comes in, she has abdominal pain, blood loss from the vagina, right? What is this? You're suspecting ectopic pregnancy. So before you do anything, you're moving to the ER, you're doing type and cross, you're doing blood groups, you're going to do RH in a pregnancy, right? You don't want the mom's blood to be mixing with the fetus's blood. That's a no-go. So bleeding pregnant women, always consider RH. Coags, CBC, CMP. These run together like brothers in any bleeding case. Okay, so then you have your HCG results. The patient is pregnant. Now the treatment can vary here based on the size of what you've detected. So let's say you have an ectopic pregnancy. You do a ultrasound, and you see it on ultrasound. You see this mass. And 3 centimeters here is the number to remember. If it's less than 3 centimeters, If the HCG is less than 5,000, you can treat with methotrexate. But always remember that for some drugs, you need to pre-screen or pre-treat with certain things, right? For example, with TNF inhibitors, you need to look for TB. For methotrexate, you need to have LFTs before you start. So LFTs, then methotrexate. So always remember, before you order something, take a breath and realize, is this going to have some side effect that I need to account for before I order it? So make sure you have baseline LFTs for these kind of cases. It's going to be pretty crucial, right? Then you want to monitor renal function, liver function, because if those functions are not great, you definitely want to avoid methotrexate as well, because it can become toxic. Pain control, like I mentioned, morphine's a great one for ectopic pregnancy. And then you want to send them to OBGYN for laparotomy with vital signs Q1, because this is a emergency case. Okay. All right. So let's just go through a quick summary one more time. So after you've done your physical exam, every single case you're gonna have physical exam first. In that one, the more you choose, the merrier. Really, in very few cases are they gonna ding you for adding more exams instead of less. Okay. So in this patient, you want to order a HCG qualitative. Then you want to get, once you've gotten the HCG result, you want to prepare them for surgery. You're expecting an ectopic pregnancy, right? You put an NPO, Q1 vital checks, IV access, normal saline to help compensate for the blood they're losing. All right, transvaginal ultrasound, very important. You want to see this pregnancy. So transvaginal is great for ectopics. It's more likely to detect it than transabdominal. Right. Type and screen, blood groups RH, CBC, coags, extremely important. LFTs, if you're considering treating with methotrexate, remember 3 centimeters is the cutoff size there. All right. If the RH is negative, you're going to give RhoGAM. So always consider that results can have consequences. So RhoGAM in the cases of negative RH. Don't forget that one as well. Okay, and then after the OB does their thing and they remove the ectopic pregnancy, you want to order an outpatient follow-up in 4 days and change the location to home once the patient is stable, and then you're good to go. The case should end after that. All right, remember these couple cases for ectopic. I think it'll save you some points on the exam. All right, IBS. IBS is an interesting one. It's very common, so they love to throw it on the exam. What things do you need to look out for? Remember stool testing. Stool testing, if you remember O&P, white cell count, culture, for any kind of poop problem, you're going to be in a good sense. And also FOBT for bleeding, in some cases it's kind of useful if it's not frank or obvious. Okay, so if they say it's just diarrhea, you can throw in an FOBT there too. Stool culture and ovum parasite. Stool fat, if you're suspecting malabsorption. This is called a 72-hour stool fat test. In every case of diarrhea, you can test for it. So here we're really talking about diarrhea without blood, without frank blood, all right? Colonoscopy is a great one if it's chronic, right? In cases of chronic diarrhea where you don't see an obvious cause, throw a colonoscopy in there. It will help you out with the differential. Okay, so IBS is an emergency, so you can send them home after you've run all these tests on them, and then have a follow-up appointment in about a week. These appointment lengths can be pretty much arbitrary, but depending on how long you expect the tests to take, most tests a week, 2 weeks, you should be okay. You can put longer follow-up times after you've resolved their issue, so 3 to 6 months after you've resolved their issue. If you're still in the diagnosis process and it's not urgent, usually you'll do a week. So that's a good rule of thumb there. Okay. After you've diagnosed IBS, the colonoscopy is negative, the FOBT is negative, you do test for TSH and ESR, to look for inflammation. TSH, you know, if they have hyperthyroidism, is a great one. So don't forget TSH and diarrhea as well. So TSH, you're looking for malabsorption. You're looking for potential blood for IBD, right? You're looking for ESR for IBD as well. Then you want to get on with the treatment regimen. So that's going to be high fiber diet, reassurance. Don't forget reassurance as an order. In the order set, it's basically your counseling step. And then behavioral therapy can also be helpful to help them avoid those inflammatory foods. Lactose-free diet and loperamide are great here. A lot of causes of IBS are lactose-induced or lactose intolerance. And biofeedback and relaxation therapy is a newer thing, but really these two are the main ones, okay? Lactose intolerance, lactose-free diet, loperamide. You have to put these orders in. Don't forget lactose-free diet is an order. Diet orders are types of orders in here, okay? All right, moving on to case 6. Case 6 is depression. Now this one's great. The patient will have your SIGI caps, at least 5 of them, right? That's the formal diagnosis. 5 of SIGI caps is going to give you the formal diagnosis of depression. Now, how do you handle this? Well, you need to rule out other things first. With these non-critical cases, where you don't have an emergent situation, your first step is to rule out stuff while getting the diagnosis. So throw in a bunch of orders first. You want to get a TSH, a B12, a tox. STD test is also great in high-risk individuals. So depression and STDs are linked in some ways. So make sure you get an STD test as well in these patients. Okay, so put these orders in as routine. That's not an extreme emergency. Then you want to get straight to treatment. So you can do fluoxetine. You can have lorazepam if they're anxious. Exercise is an order. So don't forget exercise for depression is a great treatment, and patient education. Okay, psych can be consulted for medication follow-up, and then every 2 to 8 weeks. I usually like to do 2 weeks for depression. It's a great in between. Now, if you're suspecting a hormonal cause, if you have more reason to suspect hormones are involved based on the physical exam, based on additional findings in the presentation, cosentropin for Addison's is a great one, and dexamethasone suppression test for Cushing's, not Cushing's here, is also something you should consider if you're suspecting an additional diagnosis. If the case doesn't end at that point, you know you've missed something, go back and test for your differentials because you might have gone too far. Okay, and always it's better to grab the diagnosis and end the case than to leave the case unended and stay kind of confused. Just throw in more tests. You're likely to snag a few extra points even if you miss the initial diagnosis. Alright, case 7, vaginal candidiasis, also a very common thing. You'll notice a trend with these guys. These tests are always pretty common things that you see day in and day out in the hospital. I mean, if you're in a highly specialized field, you probably won't see these, but for most people, family medicine, these are going to be your bread and butter cases. Even OBGYN, a lot of these are going to be your bread and butter OBGYN cases. Okay, even pediatrics, you're going to have some pediatric cases in there. Make sure you know how to handle them, because they'll throw anything and everything onto these, and usually it'll be a representative sample, so most of them will be IM. There'll be a few surgery, there'll be a few peds and OB, and a few psych. All right, so vaginal candidiasis, what do you do? How do you handle it? Really here you want to check vaginal pH, because you'll expect the pH to be high instead of low, or just normal, right? Vaginal candidiasis has a pH of 4. I think it's 4.5 or 4.7 if I remember correctly. It's in the 4s. It's not going to be changed much from the normal baseline, right? Also microscopy for these vaginal excretion cases. Microscopy is going to help you a lot. Trichomonas is going to pop up on there. Bacterial vaginitis is going to pop up on there. So always make sure you order a microscopy on vaginal cases. It'll be extremely helpful. Cultures is also important. Gonorrhea, chlamydia, common STDs here. Common things are common. And you also, if you run an STDs test, you won't be dinged for running additional ones, because these STDs like to run in groups. So syphilis, HIV, Hep B, are additional tests you want to screen for in higher risk people. So if you're already suspecting STDs, go for a broader range of them instead of a narrow one, because they'll give you points for screening for others. Okay. Treating vaginal candidiasis, meconazole, clotrimazole, these are suppositories, so they're topical treatments. They're great for vaginal candidiasis, and usually they're the mainstay of treatment. Or you can do fluconazole oral for ×1 if the patient for some reason can't do multiple treatments. Okay, and then you'll follow up in 2 weeks after they've completed their treatment course. Usually these treatment courses are about 2 weeks, and see how they did. Usually the problems will resolve by then. Whenever the patient's doing better, they usually will let you know in the stem. Once you've ordered a significant amount of what they want, the patient will let you know, oh, I'm feeling better, or you've hit the main nail on the head. They'll give you a little prompt to let you know you're on the right track, or they'll give you a little prompt to let you know you're on the wrong track if you've gone in the opposite direction. Okay, so case 8, confusion in the elderly, another great one. Very, very common. Confusion in the elderly, this is one of those cases where rule out is king. Rule out all the causes of confusion that are not dementia, for example. So alcohol, you want to ask. Diet, you want to ask. Check these two and make sure these are in the history, okay? Depression is another great differential, right? You want to test for B12, thyroid, alcohol, and pH. Okay, so this is an MRI. These are going to definitely help you rule out confusion in an elderly person. B12 thyroid, alcohol, and pH. B12 thyroid drugs and pH. Very, very important. If they are in these stages of early dementia, right? Cholinesterase inhibitors or Alzheimer's, right? Cholinesterase inhibitors are great. Vitamin E is also helpful if the person doesn't have heart disease. For people who have concomitant psychosis, aripiprazole is the way to go. Definitely counsel these people on sleep hygiene. Don't drive. Advanced directives are also important, especially in the elderly. So remember, in the elderly, you can put in an order to get an advanced directive if you feel they're going to have a poor outcome or if their quality of life is going to be significantly decreased to the point where you don't think they have much time left. Definitely get an advanced directive. You will get points for it, okay? So in this elderly person, routine labs, I'm throwing CBC, I'm throwing BMP. I'm going to know if they're anemic or not. We're going to do TSH, vitamin B12, head CT or MRI. I'm looking for normal pressure hydrocephalus. That's going to be my first barrage of labs, okay? These are all routine. There's no urgency here. Then I'm going to book a follow-up in a week. Remember, usually it'll take a week to get a huge ton of your tests back. So manage this guy outpatient. Book a follow-up in a week. Then I'm throwing, if it does turn out to look like Alzheimer's, right? If everything's kind of within normal limits, then I'm going to treat for Alzheimer's dementia. That's donepezil. That's vitamin E. That's olanzapine if they were having psychotic symptoms, right? And counseling. Counseling is an important one too. Throw some counseling in there at the end of every case. It will snatch you a few points. Okay, so Alzheimer's, dementia, donepezil here, remember it. Remember vitamin E. If there's no heart problems, that'll snag you a point as well. Always remember to test for the differential early on. That's number 1. Okay, and if they're psychotic, add an antipsychotic. Olanzapine, aripiprazole, both great choices. Next, COPD. See how I told you these are all pretty common? Like, none of these are out of the woods, will get you by surprise. Usually the diagnosis through the question stem is pretty straightforward, so you won't have a problem with the diagnosis, okay? The only thing that you could run into roadblocks is if you ordered something incorrectly, or you did something that is not treating the condition or not diagnosing it properly, then the patient will give you some complaints. Okay, so COPD exacerbation, this is more of an emergent case, right? So In this case, what am I doing? It's an emergency, right? So I'm going to elevate the head of the bed, pulse ox, oxygen, IV access, cardiac monitor. Those are all extremely important first steps, okay? Then I'm going to do my exam. I'm going to do my expiratory flow rate, pulmonary expiratory flow rate, Q1. So I'm going to do my spirometry kind of PEFR test. It's very important in these people. It'll help you monitor their respiratory status, and it also determines treatment. So PEFRs are done Q1, chest x-rays, ABGs, ECGs, CBC, BMP, all extremely important. I'm throwing an albuterol in there at this point because I'm pretty sure this is COPD. Okay, and this is all done stat. COPD exacerbations are stat orders. Okay. Now, I'm inpatient at this point, right? I've gone to the ED. I've gone from ED to inpatient. After about 30 minutes, I'm going to pay attention to my PEFR, see how it looks like, if it's improving, if it's getting worse. If it's not changing much, I'm going to add ipratropium, right? Methylprednisolone IV and IV antibiotics. Those are all excellent drugs for COPD exacerbations. So remember, albuterol, ipratropium, methylprednisolone, and IV antibiotics are your 4 mainstay drugs for COPD exacerbation. All right, and usually after you give all those, the patient in the question stem will say they've improved. So key main points here, I've bolded them for you. Make sure elevate head of the bed is in order there. PEFR is definitely one you need to throw in, okay? This is going to let you know the status. After improvement, you can transfer to the ward from the ED. Make sure you change IV meds to PO as tolerated, right? You can also, so here are your drugs: O2, ipratropium and albuterol, PO steroids, empiric antibiotics. Boom, you've covered COPD with these 4 things. All right. You can do non-invasive ventilation, NIPPV, non-invasive positive pressure ventilation, if the CO2 is greater than 45 or the pH is less than 7.3. Okay. And move on to mechanical vent if you see severe respiratory distress, hypoxia, acidosis. So judge the vitals very, very importantly on these patients and see what kind of respiratory intervention they'll need. In 90% of cases, I think O2 will get you through, but it's all case dependent, of course. Okay. Make sure to change IV meds to PO. This is a great case where in emergency medicine, you start IV and then you move to PO once they're more stable. Steroids is one of those things you need to do that with, okay? And that's pretty much it, I think, for this case, right? Okay. So, another thing is to make sure their saturation is about 88%. You don't want to give too much oxygen and cause oxygen toxicity. In these cases, towards the end, vaccinations is important. Pneumovax and smoking counseling, boom, excellent end of case throw-ons if you want to end the case well. So remember, when you're ending the case, this is another key point. When you're ending the case, you want to think, can I give this person counseling? Which every time you will be able to. Can I give this person any preventative medication or vaccinations? And when should I schedule the follow-up? Okay. And usually you can schedule the follow-up for this patient in a few months if they don't have another exacerbation. Right? Okay. So expiratory flow rate, PEFR, pulmonary expiratory flow rate, is a great indicator here for COPD. Always make sure you get it in these cases. Next, we have a breast mass. So this is the last case I think we'll run through, case 10. We'll keep doing 10 more cases in the next one if people want more. So this is a breast mass. What do you need to do? What do you need to know about ordering things here? So mammography in people older than 35. 35 is your key age here. In less than 35, you want to do ultrasound. You can always do both if you're super concerned. So if it's over 35 and you throw on an ultrasound, nobody's going to hurt you. But if it's under 35 and you're jumping straight to mammography, then that's incorrect. Okay. So just remember, 35, adding an ultrasound on there won't kill you, but make sure you know that age separation, okay? Excisional biopsy, once you've determined that the mass is either looks funny or it's above a certain size. I think for breast masses is above 1 centimeter, then you can do either excisional biopsy or fine needle aspiration. And then for things that look benign, make sure you do reassurance. And common women health screens like pap smears, 21 every 3 years, those are ordered. So if the woman is due for a pap smear, make sure you throw on towards the end of the case those common reordered things like colonoscopies, pap smears. Health maintenance stuff is also big towards the end, so on top of counseling you can throw that in there. Counseling, follow-up, health maintenance, extremely 3 of the important endpoints. Okay. All right. So in this case, the woman, usually won't present with any vital sign changes. She won't come to the ED. She'll come to the outpatient clinic. These are all routine things you want to order. Okay. So in 35, you'll do a mammography and a fine needle aspiration, or an excisional biopsy if it's small enough. And then you want to counsel on things like safe sex, contraception, smoking cessation, alcohol, right? Regular exercise, things like that, because this is a routine things at the end of the visit you want to throw in there, okay? And then if it seems benign, you can schedule visits every 4 months after that. So really the age thing was the thing I wanted to mention for this case. Make sure ultrasound and mammography are different in your brain. And hopefully this was helpful. I'll see you guys in the next video.